Alexandra, are you on the line?
Yes, I am.
Okay, great.
And I
We're gonna start in probably about 2 minutes.
Okay.
And while whatever device that you have, if it has a mute button, go ahead and use the mute button.
All right. I forgot to disconnect my phone. Can you repeat what you just said, please? Andrew?
Yes.
Could you just repeat the last thing you were saying, please?
Just do whatever you need to do to mute your phone.
Yeah, I did. You mean the one in the Andrew? You meant phone in the Ready Talk conference control?
You're calling in? Your voice is on a phone, not on the computer, right?
No, it's on the computer.
Oh, okay. Then if you can mute the microphone on your computer,
okay,
that would be great because we can hear some sounds. Okay.
But should I mute myself and the participants part? Okay, let me.
If you could just mute yourself, and you can unmute when it gets to your time to present.
I can't believe this. Cannot. Can you ask Noel to mute me? Before, when I pressed the right hand button, it gave me the possibility to mute myself, but now it doesn't for some reason.
Yeah, for some reason we cannot mute particular. If you're a presenter, we can't mute you. And so if there's anything that you can do to cover up a microphone or whatever because of the sounds that we hear.
Hey, Andrew, it's Catherine.
Hi.
Good morning.
There's nothing I can do.
Okay. Well, if there's any, that's just try your best. And if the background sounds, we'll just say something.
Present. Can you hear me? Andrew?
Who is this? Who's speaking?
Oh, I was thinking you couldn't hear me. This is Bianca. I didn't know if attendees are automatically muted, or should I keep mine on mute for myself?
If everybody could hold for the call, I'll be giving logistical instructions
okay.
in a minute. And then, but right now I'm just seeing if Alexandra, one of the presenters, can mute.
Okay,
so
no.
I'll be back in about 30 seconds.
You are now being connected to the conference. Please stand by.
Yeah. I'm wondering if we can mute.
The conference is being recorded.
Okay, so I think we're going to go ahead and begin the call. What I'd like people to do...
the conference is now in listen-only mode.
All right, so at this point in time, I've muted everybody on the conference. If you're not able to hear me, hopefully you can hear me, but if you're having problems, then you can text me a message. Welcome to today's call. My name is Andrew Park, and there will be a few presenters on today's call. Let me go over the logistics and goals of the call. Logistically, what I'd like people to do is, if they have a device that they can mute on their own, to mute their phones or microphones during the presentation from their end. We will be muting everybody like we are now, but there'll be times when we have to unmute everybody. Be particularly attentive if you have hold music on your phone, to either make sure you just don't put your phone on hold, or that music isn't transmitted into the conference call. You'll also see a chat on the left-hand side of your browser if you're using the browser interface, possibly on the lower left. We ask that you make comments and ask any questions in that chat room. There's a little space to type a message at the bottom there. And while people are speaking, go ahead and write any questions or comments that you have. What we will do is we'll have both speakers speak, and then we're going to have plenty of time for questions and comments at the very end. We will also be recording this webinar, so the recording has already started, and we will put a copy of the video with the audio on our website as soon as we can. Okay, so let me at this point introduce both speakers, but before that, let me say that a week ago, of course, everybody here in America, not everybody, but many of us woke up assuming we'd have a new president that was somewhat pro-gay and would not be creating as much prejudice and stigma as we suspect the other person will. And in fact, a week ago, minus one day, we all woke up with the realization that prejudice and stigma is going to be possibly a bigger part of our lives than we had hoped. So this is a very timely conversation both in the U.S. and internationally. The goals are for everybody on this call to understand the minority stress model, particularly how the model has been used in policy discussions. So for the advocates on the call, one of my goals is for folks to understand how the minority stress model works so that it can be used during discussions about policy and cultural demands. And then also to have a little discussion about how we can increase the knowledge about the well-being of LGBT people in the future and continue this kind of research and data collection. Okay, the first of the two speakers, and I'm going to just introduce both of them right now. The first speaker is Ilan Myers. Ilan is a Williams Distinguished Senior Scholar for Public Policy at the Williams Institute. He is the world's leading expert on the application of the minority stress model to issues of sexual orientation and gender identity. And we're very lucky to have him here. He has used his expertise to help inform the policymaking processes in several policy disputes. He was a major component of the expert witness panels during gay marriage here in the U.S., and he's also filed documents in Russia, and he's an expert witness in the case that just went to one of its first hearings, the case against Scott Lively brought by Ugandans. Then we also have Dr. Alexandra Huic from the University of Zagreb, and the researchers at the University of Zagreb have taken the minority stress model to see whether it would apply and could be demonstrated in the population in Croatia. And so Alexandra is going to talk about that. But first, let's go to Ilan. And Ilan, are you there? Can you speak?
The conference is no longer in listen-only mode.
Can you hear me?
Yes, I can hear you. Go ahead. Okay,
great. Thank you, Andrew. I'm going to talk, as Andrew said, about minority stress. In particular, I divided my talk into 3 sections. First, I'll say a few words on LGBT health disparities. Then I will talk about minority stress as a cause of health disparities and generally as a cause of health problems for LGBT people.
I'm just starting a webinar, so I've got to...
Third, I will talk a little bit about the implications for law and policy based on the minority stress model.
It's happening Saturday.
First, talking about health disparities. The idea of health disparities is something that here in the United States we often use as a framework for understanding issues related to public health. It's not a very old...
The conference has been muted.
Sorry, unmuted.
The conference has been muted. The conference has been unmuted.
In the United
The conference has been unmuted.
Health disparities paradigm beginning in around 1999, where the Public Health Services has included reducing health disparities in its Healthy People 2010, which was published in 2000, and later in Healthy People 2020, which was published in 2010. Healthy People is a document that describes for the United States its health goals. And the goal of reducing health disparities is an important one. Just to indicate very briefly, health disparities relate to any differences in the health of population that is associated with social conditions or conditions that are usually thought to be related to social issues, and is different, therefore, than any inherent biological developmental causes, such as the differences in aging or differences between populations that are not related to any social issues. In terms of health disparities of LGBT people, there has been a lot of research, especially on LGBT populations. This is an article by King from 2008. And basically, King showed that LGBT people were at higher risk for suicidal behavior, mental disorders, and substance misuse and dependence, comparing them with heterosexual people. So this is where the health disparities perspective is when we're comparing two populations. And King found, and again, this is a meta-analysis that is a summary of a number of studies that were conducted in different places. And he found that the findings were similar in men and women, but lesbian and bisexual women were at particular risk for substance dependence, while lifetime suicide risk was especially high for men. So often we found differences, but those are more subtle differences. Overall, LGBT people and certainly transgender people, although few research articles, are at higher risk for those disorders. Another example, this is a study of older adults in the United States, specifically in Washington State. And in the blue, you see the LGBT population compared with the straight population. And you see the outcomes are frequent physical health problems, mental health problems, disability, obesity, asthma, and diabetes. And with one exception of obesity and diabetes in gay men, the LGBT groups are always at higher risk. From the same study, this is findings relating to health behaviors showing smoking and excessive drinking to be especially higher problem for the LGBT population compared with straight. And again, here the exception is HIV testing, where LGBT people seem to be doing better than heterosexuals. This is showing results from several studies in different countries, the United States, the United Kingdom, and the Netherlands, looking at 12 months prevalence of mental health problems, and specifically in men, and again showing gay men compared to heterosexual men having higher rates of all of those disorders. These slides will be available later, so if you do not have time now to examine them carefully, you can look at it again later. And finally, this is the same aggregation of studies from the United States, United Kingdom, the Netherlands, and Australia as well here, showing again that for gay men compared with heterosexual men, suicide attempts are at a higher risk area. And finally, this is findings from the United States nationally, looking at youth in a high school and showing that youth are at higher risk or attempting suicide and feeling bad, and then looking at some of the stressors, including sexual violence, physical violence, being bullied, electronically being bullied, and being injured in a physical fight in school, again showing in the dark blue that the LGBTQ group is at higher exposure and higher risk compared with heterosexual. So we're looking at all these health problems and health disparities. The minority stress theory is based on various other theories that have been established in psychology, sociology, and public health fields, including theories related to stress, to prejudice and stigma, and the social embeddedness of health problems. And the basic premise is that prejudice and stigma are issues that affect LGBT people compared to heterosexual cisgender individuals, and that this causes adverse health outcomes, including mental health disorders. So again, very briefly, and the articles and the slides will be available later if you are interested. It basically shows, if you look at the right hand, these are the health outcomes, and on the left hand, these are the circumstances in the environment. And what the model basically shows is that social problems, including related to sexual orientation, race, ethnicity, gender, and other social disadvantaged statuses, are causing LGBT people to have increased exposure to center stressors. And I just showed you an example in the YRBS data of the LGBTQ youth of being exposed to bullying, being exposed to physical violence, and we all know of many examples where LGBT people would be exposed to higher levels of stress. The minority stress model, which is in the middle column, I'm not sure if you can see my pointer, and the minority stress model goes further than looking at those kinds of events or conditions in the environment to look at also how these are internalized by people and how prejudice and stigma can have a great impact on a person even without those stressors, which as we know are a huge problem for LGBT people. But even
Ilan, this is hey, Ilan, this is Andrew Park. If I could remind people, because we've had 3%, we've unmuted everybody. So if you could do whatever you can to mute your phone or cover the microphone with a Post-it note, or take some other measure, because we're hearing conversations in the backgrounds of people's offices. Thanks very much. Okay, we're still on the slide. Go ahead,
Okay,
Ilan, sorry.
so as I said, that the minority stresses are not only the external stressors such as violence and bullying, but also the way that those are internalized by people, and include things like internalized homophobia, which is the internalization of negative attitudes that LGBT people learn in their social processes, just in the socialization process, just as heterosexual cisgender persons learn do negative things about LGBT people, so do LGBT people themselves. And internalized homophobia, expectations of rejection, are the internalization of those negative prejudice and stigma and how they affect LGBT people themselves. And finally, concealment, which is whether people are out or not out in terms of their sexual orientation or gender identity, is an interesting stressor because on one hand, it is actually a coping mechanism that people use to, in a sense, hide and therefore protect themselves. So we know from research that people who are less out are actually less likely to be exposed to violence, anti-gay violence. But at the same time, the concealing one's sexual orientation or gender identity also has a lot of cost in terms of the stress that it exposes a person with concealing, and those as well have negative health outcomes. So this is in very brief the model of minority stress. And I want to add a reference to the specific issues associated with minority stress in transgender people. This is from a paper by Testa and others in 2015 that I highly recommend. And it's showing that the same processes work in similar ways, but a very important aspect of the minority stress for transgender people, of course, is non-affirmation of gender identity, which is the refusal or the ignorant lack of acknowledgement of one's gender identity by others, either in interpersonal or institutional encounters. For example, refusal to provide IDs, or in interpersonal ways, a person refusing to acknowledge the transgender person's gender identity, referring to them by the wrong gender. I just want to say a couple of words about minority stress studies outside of the United States. Unfortunately, we have a lot of studies, but unfortunately, mostly they're focused on European countries, and mostly they're focused on countries where LGBT people have a better social environment. This is understandable that in some countries it will be much harder to conduct this kind of studies. But a lot of the evidence we have are from studies that are more positive. So far, we haven't seen any distinct cross-cultural findings that would suggest some kind of differences that we can detect. But as I said, we don't have studies in many countries. Most of the studies that have tested it have shown support for minority stress, although some studies, like in Holland, are showing that despite changes in the social environment, more positive social environment, LGBT people continue to experience health disparities, something that has been referred by Agarwal and Garrett as the Dutch paradox, where in Holland they're seeing continued health disparities. Finally, in the last 2 minutes that I have, I want to talk a little bit about how it's been used, how the minority stress research has been used. And I think one of the important things to think about is the way the minority stress framework basically reframes health in a social context. So whereas for example, in the Russia experience that Andrew mentioned earlier, where I wrote an opinion or declaration to the European Court of Human Rights, I was responding to a Russian document that was describing health disparities, but pointing those as evidence that there's something wrong with LGBT people, and showing, you see, they're depressed because there's something wrong about them. And what the minority stress framework basically does is it reframes it and reposits the causes of health problems in prejudice and stigma rather than in the person who is experiencing prejudice and stigma, and in some ways changes the kind of blame the victim perspective, such as the one that was displayed in that particular case. It shows that prejudice and stigma are fundamental causes of health disparities, and also identifies the specific stress processes that we can examine in either studies or policy or law. The model is expandable to fitting into different social settings. So even though I identified these particular processes that I showed earlier, there's no reason to think that one cannot think of other ones. And it also points to areas of intervention. It shows this is an example of differences across countries. This is Uganda, and this is a really interesting map by ILGA that shows the state of sexual orientation legal issues around the world. I would point you to that website. But I wanted to also talk about the resilience that I didn't mention when I discussed the minority stress model. Part of minority stress is also thinking about resilience and the kind of things that people do to against oppression. And this is an example of an LGBT Pride March last year in Uganda that demonstrates that. And finally, I want to show, if you look at the minority stress model, you can also identify places where you can intervene or advocate for intervening, all the way from the left side, looking at the more upstream, broader types of legislation and education efforts that can affect the entire community, to the more individual specific, if you look all the way on the right hand of the model, for example, developing services and accessible mental health services, for example, for LGBT people, or providing school counseling and things of that nature. So interventions across the different levels of social and individual perspectives. There are several documents on the Williams Institute website that you're welcome to review that demonstrate some of how I have personally used this in these legal court cases that Andrew mentioned. And I'm very happy to receive any questions, further questions after this conference via email. So thank you, and I move it back to Andrew.
Hi, this is Andrew. I hope you can hear me. This is the first time we've all done a conference call on this platform, so thank you for your patience. And our next panelist is Sasha. Dr. Huic is from the University of Zagreb, and Ilan was asked to present at a conference in Croatia earlier this year, and spent time with some researchers in Croatia.
Thank you for your patience. Please continue to hold. Someone should
okay.
be
someone has us on hold, so we may have to face some hold music during Sasha's presentation. But Sasha, why don't you go ahead and tell us what you have to say?
Okay. Hello, everyone. Can you hear me? Just to check.
Yes.
Yes. Yes. Okay. Thank you very much. Hi, everyone. So thank you, Professor Mayer, for introducing us to and giving us this overview of the minority stress model. And what I would like to do is talk about some research that we've done testing this model in Croatia. I have to say just up front, we did focus mainly on the issues of lesbian women, gay men, and bisexual women and men, which in Croatia, just as in many contemporary societies today, are forced to sort of fly against the mainstream. Being straight, being hetero is what is considered normal. And this creates, as we've heard, a very negative context with which sexual minorities have to cope. And you may know Croatia is a European country. It's depending on different divisions, it's either Central European or East European country, which has a very specific context. First, I have to say, equal rights legislature does exist, but as you can see, this has been accomplished by a very recent Civil Partnership Act. So formally, LGBTs enjoy much of the same rights as heterosexual citizens, except the right to adopt children. However, at the level of implementing this legislature, as well as legislature on the combating against hate crimes and the acts that deal with discrimination, which all exist. This level, which would make a huge difference in the lives of gays and lesbians and bisexual people, is very poor. For example, there are no track records of hate crimes, and this all leads to LGBTs having no confidence in authorities. So another problem is created because they do not really report when they have been targets of violence or discriminated against because of their sexual orientation. Also, we have a very rich research tradition of general population attitudes towards LGBT, which range from being negative to mildly positive. Research that has been done on nationally representative samples show gloomier data. For example, studies like European Value Survey or European Social Survey show that about 60 to 70% of Croatian citizens do not think that homosexuality can ever be justified. And even amongst people who are traditionally more liberal, like students or highly educated people, attitudes are at best mildly positive. And this is true both for general attitudes and for attitudes towards LG rights. People are also relatively ready to discriminate against LGs, and this is what they're ready to admit in surveys, and they're not particularly ready to engage in any sort of affirmative actions, especially if these are actions like involving oneself in the work of an LGBT NGO, which includes more effort and direct contact with sexual minorities. So as you can see, this might not paint such an extremely negative picture, but in comparison to other European countries, Croatia is among the most homophobic. You can see on this slide, we're at the bottom end, and this is data spanning almost 10 years, and we have some even more recent data showing that attitudes and prejudice of the general public are not getting any more positive, even as time passes by. So this creates a rather negative context for LGBTs living in Croatia today. And in our research, we then wanted to investigate whether LGBTs will perceive this context as detrimental to their opportunities, and will this lead to higher instances of stressors that is proposed by the minority stress model. Is their mental health impaired because of these higher levels of stress? And we were also interested, along with these risk factors, are there any protective factors such as social support, which previous research has shown that it has a buffering effect, and this is a negative association of stress on mental health. So we designed a very comprehensive online questionnaire and used very different resources to gather data. Since the main researchers are university teachers as well as researchers, we had help from our students who sent our links to the web survey to their acquaintances, who then forwarded on to their acquaintances and so on. And this, using the snowballing technique, gathered a large part of our sample, and we also worked with different Croatian LGBT NGOs and websites. They were, I have to say, more than happy to help us out to publish our link to the web survey on their web pages and forward it through their mailing lists. And these efforts resulted in a total sample of just over 400 participants, lesbians, gays, bisexual women and men, with a very wide age range, from different backgrounds, both urban and rural. And as you can see, most of them were out to their friends, with less out, being out to their families, and reflecting the very society. There was a very small number of their fathers. So what do the results tell us? Well, a very high percentage, 74%, had experienced at least some form of violence and discrimination during their lifetime, mostly in the form of insults, foul language, threats, but percentages of physical, financial, and sexual violence are also considerably high. And here you can see a picture of a typical wall sign that LGBTs in Croatia are forced to look at every day walking down the street. It says "kill gays" in Croatian. And our data is very comparable to other research studies in Croatia. For example, according to the data from the European Agency for Fundamental Human Rights, 60% had in the prior year felt discriminated against or stigmatized. And from some research, there is some data dating back to 2006 showing the same percentages, so things haven't really picked up in the last 10 years. So we're not surprised to see with these high percentages of violence and discrimination that LGBT people are aware that they have a minority status in Croatia. Aware that there is prejudice and discrimination and violence against them, and the more aware they are of this, the more they conceal their sexual orientation, which, as Professor Mayer already said, can be helpful. It doesn't make them targets of violence and discrimination, but the more that they actively conceal their sexual orientation, the worse they are off in terms of mental health.
Hi, Alexandra.
Yeah.
Alexandra, I think we need to pause for a moment. It sounds like there's somebody might be calling in on a cell phone and texting or something. But again, I'd like to ask, if you're calling in by computer on a Windows machine, go to the bottom right and mute your microphone that way. If you're calling in by phone, try to mute your phone by the mute button, or you can use the number *6. Okay, thanks. Go ahead, Alexandra.
Okay, thanks. So in other words, LGBTs are forced by the society to conceal their identity, which in turn makes them worse off in terms of their mental health. And being forced to conceal this identity has one other very negative consequence, and that is that it impairs their opportunity for social support. And it is exactly the social support that we found was very important for their mental health. So the less social support they had, the worse off they were with regard to their depression, anxiety, and stress symptoms. We also got very similar data when we looked into their quality of life, just of course in the opposite direction, but the results were very much the same. Of course, I just showed you today a small part because we didn't have a lot of time, but we can still conclude that our results do support the minority stress model in Croatia, which I think is very important, echoing what Professor Mayer said earlier. The model relies heavily on context, and research in different contexts and cultures is crucial to empirically identify both risk factors and protective factors, which can then be a basis for further preventive efforts and interventions. Just as a small example, there was a movement where people were walking around and adding just one letter to that "Kill Gays" wall sign that I showed you earlier, turned the same wall sign into "Love Gays." Of course, can be convenient in our language, but still it's a very simple and nice intervention. And just to conclude with some of my thoughts about what can then help with future research, and I think that connecting and the cooperation between social science researchers and LGBT community resources is the key to move forward to get the most quality research. Social scientists have this knowledge of theory and methodology, they have research experience and access to research tools. And if they're not informed by the problems and firsthand experience of LGBT community, they are at risk to do science for the science sake. And the community can rely on social science researchers to be able to get high quality, reliable, valid, theoretically valid data, which then will not just lead to highest quality of research, but will then inform further public policies and affirmative actions in the best possible way. And thank you very much. Here are just some of our Croatian references for your information. I've put down the ones that are in English, but my email is here as well, so I would be happy to answer any of your questions. Thank you.
Thank you very much, both of you. I really appreciate you doing this, and we have a bunch of questions that have piled up in the text box and have been communicated to me. Let me start with Ilan, but this touches on the data collection question as well. Ilan, what is the state of research in terms of applying the minority stress process to the issue of gender identity and transgender and gender nonconforming people?
Yes, so I've seen the questions and I appreciate the note. The slides that I've showed have not shown the disparities by gender identity because I've used primarily community-based or studies that aggregate data from a number of studies. But there are, of course, a lot of studies, individual studies that are showing and have shown huge and even bigger disparities by gender identity. I've also posted several articles in the slides, and again, we will be able to share with you both the slides and the resource articles. In particular, the TESCA article from 2016 that I noted earlier, and the Hendricks and TESCA article that I showed earlier, both of them describe more specifically issues related to gender identity and transgender populations. So the findings are beginning to emerge. There are not as many studies of minority stress as there are of LGBT people, but certainly the issues are relevant in the same way, with the additional stressor that was noted in the TESA article and by Jay Sibelius, specifically about gender affirmation. Just for those of you who are interested, I would point out that in February, the American Journal of Public Health will have a special issue that includes several articles that describe transgender population, health issues related to transgender population, and we're very happy to have a couple of papers on that issue as well. So you'll see more there. So that's something that we will make sure to include in the materials that we will publish online.
Okay, and again, a reminder for people to mute their phones. What other groups has a minority stress model been applied to? So
I saw a question in particular regarding race ethnicity, and this is a very important question. The minority stress model specifically has been applied to LGBT people, but in the box that I showed you where it says social conditions, I mentioned several disadvantaged groups, including groups related to race ethnicity, so that'll be racial ethnic minorities, as well as gender. And in my own studies, I've usually included looking at gender, and we just discussed transgender identity, but also race ethnicity, looking at the intersectionality perspective. So this is still looking at issues and how they impact sexual orientation and gender identity, but obviously this connection with race, ethnicity, and national origin would be a very important addition to the model, and there's been many studies that looked at those issues, showing some differences, some more surprising findings related to racism. For example, some studies suggest that looking at Black LGBT people, there is actually greater resilience, and some people suggested that dealing with racism is actually prepared you better to deal with issues related with homophobia and transphobia. On the other side of this is also the fact that having more stressors related to racism and, are actually more burdening. So these are the kind of studies that have been done in that. Thank you.
Thanks, Ilan.
I was actually wondering if Sasha could say something about the issue of race or religion in a Croatia content, because we're very familiar with this issue in the United States, but I think there also would be something to look at in other countries.
Hi. Okay, if I understood you correctly, you broke off that there at a moment. So Croatia is a Catholic country. It's a very religious country. And one of the very important issue that impairs the context becoming more positive is the fact that during public discourse by both politicians and celebrities, and during religious talks, we can hear a lot of very negative attitudes and prejudice put out there, which unfortunately is being interpreted as freedom of speech, and not as hate speech. So there are some efforts being done, mainly by the Croatian ombudsperson for gender equality, to raise awareness for that kind of speech and about the consequences of hearing those kind of discussions and public discourse for the LGBT. But I think we're still a long way to go.
And can I ask both Ilan and Alexandra, what is the impact? Wow, I hear like 3 echoes of my voice. I apologize for that. What is the impact of having an expert like yourselves with the university credentials approach policymakers to tell them about this evidence that links some of their policies to bad health outcomes? When you've engaged in the policy discussion process, what impact do you think it's had?
Well, I think that is something that is for political scientists to assess. I think that what researchers can bring to the table is knowledge and information, and so I hope that our perspective changes the public discourse, and I think we've seen this definitely in the United States. As you increase knowledge in the public domain and among policymakers, they're better informed to make decisions. But in terms of the actual data showing the impact, I think that is still not clear. But I know for a fact that in the United States, in the marriage trials, for example, research evidence has become very, very important way of countering a lot of the rhetoric that was based only on opinion or prejudice and stigma. And by providing real data and knowledge, we are able to accomplish a lot and abolish some of those misconceptions or even purposeful lies about the issues that are under discussion.
Yep, and I can add on my part, I haven't had that much experience with going all the way up to the higher levels of policymakers, but I had great experience with different LGBT NGOs who want to learn and then use this knowledge to then influence social policy. And of course, I can imagine this is the same in the entire world and everywhere, that those who are open to doing something about it based on the research data and theory are politicians who already have a positive attitude and want to do something about it. So we are actually approached by them either than the other way around, and this of course helps a lot.
If I could try to combine two questions on the queue, what, in terms of the impact of your research, what interventions do you suggest for people providing care for sexual and gender minorities that may be experiencing minority stress? And what do you recommend in terms of self-care for sexual and gender minorities themselves?
Well, this is a question that has actually been gaining more attention in research, and there are clinical interventions using the minority stress perspective that are being developed and tested. I cannot, we don't have time right now to cover this vast literature on clinical issues, as well as on some but I would like to mention a couple of things. First of all, on an individual basis, there are, of course, important intervention, and I'm pointing to the slide again to highlight the fact that when we think of interventions, we don't want to think only at the what the study constitutes at the tertiary level, at the end individual person intervention, such as therapy or clinical care, but also along the entire continuum. I would mention, for example, the impact of political activism and community connectedness can have also on the individual as well as in the community. Some of the acts of resilience that we've seen in the LGBT community are have a complicated relationship to health and mental health. On one hand, it puts people in a lot of stress, and we have seen the same thing in the United States, as Sasha just described, when there are debates about whether you deserve rights as an LGBT person. This is very stressful and can have a negative impact. At the same time, people can gain a lot of strength from connecting with other people, from getting involved in political or social action that affirms your own identity and your own perspective. And we know from a lot of research in psychology that changing the perspective of how you think about your social identity by having a more affirmative perspective is itself a approach to therapy that helps people. So certainly getting involved in the community, and when I say the community, there are many communities of LGBT people, whether it's a trans community, whether it's a LGBT community that is specifically lesbian, black women. There's not one LGBT community, but any of these involvements can be very stressful as well as very ameliorated, very curative for people who are involved and gain strength for that.
Thanks. how do you determine the relationship between a particular prejudice event and particular health outcomes? Is that possible? Is there an issue of proximity in time, or what is the...
How do we determine the relationship?
Yeah, assuming if someone is experiencing a series of prejudice events over a long period of time, how do you determine, is it possible to determine the effect of a particular set of prejudice events amongst all the prejudice events that a person experiences?
Well, in research it is possible, and we look at these things in many different ways. We look at population differences in health outcomes. I'd mentioned Mark Householder research that shows differences between different regions in the country where there's more positive versus more negative environment, and how this is one way of testing the impact of the environment. We've also looked at specifically over time, for example, the research that I've done with David Strauss that looked at the specific impact of prejudice-related life events at the health of the people who experienced them a year later, and where we showed that it has a physical health impact. There are many, many ways that people have looked at those relationships and have shown to various degrees of impact on the experience of events on the health outcome.
And I could just add to that, I don't believe that a certain set of prejudice or a certain type of violence will lead to certain types of health outcomes. All types of violence and discrimination and stigmatization hurt, and all types will lead to worse mental health and also worse physical health in some cases. And it's exactly what we have to be aware of is that we do not have to see very extreme examples of physical violence or sexual violence. It's enough for the people just to be exposed to insults or everyday microaggressions against themselves to still have this negative impact of the stress on their mental health.
I want to thank both of you. Our time has come to an end, and I've put in the text window my email, so if people have further questions, feel free to email me, and I'll try to direct it to whoever has an answer, if one exists that I know of. And we will also post a recording of this as well as associated materials on the website and YouTube evidently. Okay. So thank you very much, everybody, and have a good day or evening.
Thank you very much.
Bye-bye.
Thanks, Orly.